It's an honor and a privilege to be here with you this afternoon, and I have to say, it is really palpable in terms of the energy and buzz that's in the room. I came in just before lunch, and people are clearly highly engaged in conversations, and I don't think it's just a sign of our personalities, but it is the nature of the work when I think the person who's trying to get the session started takes a few times to get people to come together. So you were all so busy chatting and talking, it really felt great to be here. As Joel said, I have come to academia in some ways through the world of philanthropy, government, and nonprofit. I am a person, like many of you, who has a passion for public health and human rights. Back in the early days of the HIV/AIDS epidemic, when I was working as a young staffer on Capitol Hill, it was the public health people who taught me that if we did not fundamentally deal with people's human rights first, we would not be successful with our public health interventions. I never forgot it, and it's a part of everything I do. When I went on to serve as the Executive Director of Human Rights First, some of you may well know this given your backgrounds, it started its life as the Lawyers Committee for Human Rights. So it also had a place there as a human rights organization that thought very squarely about what it was the role of law could play in the rule of law. And so it really is a pleasure to be in a room filled with people who have a deep, long commitment to public health and the role that the law can play in advancing the best health outcomes for all of us, but many who are particularly dependent on us in the health system. I am a big, big fan of the Medical Legal Partnership program, so it's a pleasure to be here with you. And speaking of partnerships, I can't think of a better partnership than those that I have at George Washington University with Joel, with Ellen, with Marcia, with many of the other people who are here today and back on campus in DC. It's really almost an unexpected joy to realize that I go to work every day and have the opportunity to work with other very talented people who are working on issues from a different perspective, but we all come right together around the interests that we're particularly focused on. I also have the pleasure of working very closely with Sarah Rosenbaum. Some of you may know Sarah. I think of her as a super smart force of nature. And she and I together work on this community benefit project that I'm going to share some background about with you today. So I not only have the pleasure of the other colleagues from the Medical Legal Partnership and other parts of the department, but Sarah Rosenbaum and I are very close colleagues, and a lot of what you'll hear today is based on how we both think about these issues. So, like many, if not all of you in the room, a number of us have been thinking long and hard and working very hard for years on how we would think in a very effective, strategic way of beginning to get public health principles and practices integrated into the healthcare system. Been thinking about it for a long time, trying to find all sorts of different ways, and now with the Affordable Care Act, structured in a way that I believe signals to everyone that the heart and soul of our health system is wellness, wellness and prevention. Sarah and I are particularly interested in thinking about what is the role that community benefit obligations can play in helping to advance those goals of the Affordable Care Act. If what we are trying to do is think about structuring our health system and its financing mechanisms to really focus on prevention and wellness, and in the words of the Robert Wood Johnson Foundation, building a culture of health, then we are all going to need to think about the various ways in which we identify resources to make that happen. We all know there will not just be this one big fat pot of money that has the word public health on it. In fact, I think that wouldn't be appropriate. What we want are those practices and principles to be integrated throughout the system, and for the ways in which we think about financing all of our prevention and care services to be paid for through those various mechanisms. So when the Affordable Care Act was passed, we at the George Washington University began to think, in addition to everything else that all of us in the room know about in terms of expanding coverage, Medicaid coverage, looking at all of the sort of basic services that we would include for folks in the system, we also said, you know, there is a fundamental improving the health of communities is a central aim of public health, and improving community health is a central tenet of the Affordable Care Act. There is a section in the Affordable Care Act. Some of you I know some background on this, but I want to be sure to go over it so that all of us in the room have a good sense of where we're coming from before we have a conversation with Woody and the rest of you about how we can think about engaging in the community benefit process to take advantage of some of those resources and decisions on the part of hospitals. But there is a section in the Affordable Care Act, 9007, that calls on strengthening and clarifying these community benefit obligations that all tax-exempt hospitals have. There are about 5,000 hospitals in the United States, about 3,000 are tax-exempt hospitals, so we're talking about a very large group of hospitals who are required under their tax-exempt status to make a community benefit obligation. Oops, we have gone further here. I don't have these in front of me. There we go. There. So the concept of community benefit has been around for a very long time as an IRS compliance issue. If, in fact, you are not going to pay taxes, there is a requirement in turn that a hospital will make a contribution or an obligation to its local community. It dates back to the 1950s. In 1969, and for the most part, that usually meant charity care. That if someone came to the hospital through the emergency room usually and needed care, the hospital would provide that service even if in fact there was no mechanism for paying for that. So for the most part, community benefit was always perceived as being a charity care mechanism. In 1969, the IRS broadened that categorization, if you will, and said, you know, in addition to charity care, we will recognize a number of other things as being countable toward a tax-exempt hospital's community benefit obligation. That would include the difference between what it costs to provide the care and what Medicaid might reimburse. It would include research. It would include health professions training. And importantly, and I'll focus on this over the course of my remarks, a category called community health improvement. But it starts with charity care. In 1969, the IRS says, not just charity care, there are other activities the hospital engages in that we'll consider to be community benefit to meet your obligation, and it broadens out into those categories. In 2009, the IRS introduces a worksheet, a form, that every tax-exempt hospital must fill out when it files its annual 990 form with the IRS. So I'm sure, as most of you all know, every nonprofit organization in the United States puts in a 990 form to the IRS. Tax-exempt hospitals have an extra burden of reporting. They fill out this Schedule H worksheet. What it does is tell the IRS how the community benefit dollars are allocated across those categories. So it's on that worksheet that they are reporting on how much to charity care, how much to the Medicaid differential, how much to community health improvement, et cetera. There are a number of parts of this Schedule H worksheet. Some of you are familiar with it. I'm going to focus today primarily on Part 1 and Part 2. I'll show you those in a moment. Part 3, some of you may well be familiar with because that's also where the tax-exempt hospitals are reporting on their collection practices. And I know there are lots of people in the room who have addressed those issues. So this is what it looks like. I give this to you because for most, as Sarah and I always say, for most mere mortals, this would be a fairly intimidating form. It's not easy to read. It usually is in this tiny print unless you blow it up yourself on a computer. Got lots of different sections and not all that easy to navigate. It's also not easy to find for the average person. In order to get access to the 990s, as most of you know, you usually have to go through GuideStar. So you'd go through GuideStar, you might find that hospital, and then you might try to find the Schedule H form, and then you might try to figure out what do all the numbers and the reporting on that form mean. Not simple, not impossible, but not necessarily a simple thing to do. On that form, and I'll tell you that we're coming up with something that is a little bit simpler. On that form, as I said, or in Part 1, that's where the hospitals will report on the charity care, financial assistance, the difference in the Medicaid costs, health professions training, subsidized health services, and then the other category of community health improvement. I just wanted you to see that those are all the allowable activities that the IRS will count when a hospital reports on its community benefit obligation. There is a Part 2 of this form that talks about community building activities, many of the activities that most of you will be quite familiar with because, in fact, these are the kinds of activities that really deal with the upstream issues of many of the health needs that you will all be engaging with the folks at the community level and around the country. So the form allows you to fill in how much of your community benefit dollars have you spent on physical improvements and housing, economic development, community support, etc. Under the Affordable Care Act, since it's been passed, the IRS has clearly stated that if a hospital spends some of its dollars on these activities, in Part 2, under community building, and points to an evidence base, it can be counted as community benefit. So it's very clear to most of us that, in fact, those are allowable activities. But I do just want to be sure you see that you report on these in a different section. So we do have a concern that some people may be a little bit worried about whether they would count. And the idea that you've got to document for the IRS what the evidence base is. A number of us have been writing pieces and engaging with the policymakers and decision makers at the IRS to try to identify some safe harbors so that if the IRS came out and said, if in fact your evidence base is a national prevention strategy, no problem. That there shouldn't be any question on the part of an individual hospital as to whether or not there's an evidence base for investing in housing, if you will, to address some fundamental health issues. But it is a separate section. It's countable. But I think as you engage with folks who are working on community benefit, one, it's important to know, and we can find you the documentation, it's countable as long as you point to an evidence base. We think that evidence base is quite easy to find, but it's in a different section, and I'll come back to that later. I do want to point out just recently, just a week or two ago, the American Hospital Association and the Catholic Health Association sent a letter, which has been made public, to the IRS suggesting that housing be moved to the community health improvement category, and I'll just come back to that later and reiterate that point. Because I'm going to talk a lot about community health improvement as part of the community benefit obligations. In terms of numbers, how much money are we talking about? How are hospitals spending these community benefit dollars? In 2013, there was a New England Journal of Medicine article that calculated that for 2009, 7.5% of total expenses for hospital and tax-exempt hospitals across the country were spent on community benefit. Of that 7.5%, approximately 6.4% of all expenses went to financial assistance and expenditures associated with Medicaid. 85% of the 7.5%. So just if you sort of follow those numbers, that's the total in community benefit spending. The lion's share of that community benefit spending is going into financial assistance and the Medicaid differential. Less than 0.5% is going into community health improvement. And I'm going to just go back here for a second. If you see, again, all of the categories that you can spend a hospital can spend community benefit dollars on, it's the less than 1% that's going into community health improvement. And if you think about, when you look at that list, community health improvement are essentially the activities outside the four walls of the hospital. That's where a hospital is reporting spending on partnering with a local school or partnering with a local community health center or partnering with many other nonprofit organizations in the community. That's where you'll see that sort of public health investment on the part of the hospital, but not necessarily the housing, the economic development, and the workforce issues that we were talking about earlier that are in the other sections. So we're working on getting those to be naturally included into the community health improvement line. So those are the numbers. I wanted to make sure everyone was clear how, in fact, the bulk of these dollars are actually being expended. So in the Affordable Care Act, so 1969, the categories get broadened. 2009, the worksheet gets developed. Hospitals are now reporting on how they allocate those dollars among the different allowable categories. With the Affordable Care Act, Section 9007 includes provisions that it's very clear that the provisions are intended to promote greater accountability and transparency on how these dollars are spent. The first thing the law says is that all tax-exempt hospitals now, every 3 years, must conduct a community health needs assessment. In the law, it says that needs assessment needs to be done in partnership with folks at the community level and people with public health expertise. So there was a recognition that if you're going to be conducting a community health needs assessment, the expectation is that there would be some participation on the part of people who've been doing this for decades. People with expertise and a really good understanding of how to do a needs assessment. The hospital is also required to be in compliance with the law to adopt an implementation strategy, essentially a statement or a plan that says, as a result of what we've learned in this needs assessment process, we, Hospital A, are going to do the following, probably in partnership, hopefully in partnership, with many community-based organizations and others in the community, but it is a statement about the response to the needs that are identified in the community health needs assessment. To be in compliance with the law, the trustees of the hospital have to sign off on the implementation strategy. So it has, in some ways, ratcheted up the visibility and awareness of the importance and the value that's being placed on community benefit spending and what the process is that hospitals are using to be able to identify the various strategies that they will be engaging in to address those needs. We said, great. We think this is a step forward, makes a whole lot of sense to us, but we thought, you know what? We think we're missing the third leg of the stool. So super important to engage with community experts and folks on the ground, think about people with public health expertise, identify what those needs are, and I will say when this first came out, many of us, probably like many of you, said, do not spend a whole lot of time trying to figure out what the needs are. There is so much data out there, there are lots of sources. That should not be the hard part in terms of access to resources and an understanding of what those needs may be. Please spend a lot of time coming together in partnership to think about what are the strategies you're going to be engaging in to address those needs. And oh, by the way, we sure think it'd be a good idea if you thought a lot about public health-based strategies that really look at the root causes of many of these conditions and can really get you the return on investment that you'd be looking for and the ability to really measure improvements in community health. So identify the need, work hard together to think about what those strategies are. And then the one thing for us that we thought was missing is there was not an easy way for folks at the community level in particular, although I think there are other audiences for this. We know there are other audiences for this. For you to go back then and see, do the dollars align with the need? So if you've gone through all the trouble to really think about what are some of the priority needs in the community, what are some of the decisions that you've made, hopefully, as I said, in collaboration with others about the strategy for addressing them, at the end of the day, do the dollars track those other two pieces of the equation? And we thought the only way you could know that is if you actually looked at how are the dollars reported on the Schedule H sheet, which says this is how we've allocated our community benefit dollars. And indeed, how much is actually being allocated into the community health improvement line? And are hospitals reporting anything in that Part 2 section around community building where an investment in housing or an investment in economic development or an investment to address a serious environmental health issue might in fact be one of the most effective ways that you could address the community need that was prioritized in that process. And so we kept thinking, well, you have that sort of really sort of daunting Schedule H worksheet. You have to go through GuideStar. So thanks to the generous support of the Robert Wood Johnson Foundation, and I know you heard from Paul this morning, and we are super grateful for that partnership. At George Washington University, working in partnership, and I'll show you who those partners are in a minute, with some other very key people, we have developed the prototype for what we're now referring to as a community benefit web tool. The goal of this tool is that anyone around the country could easily access it. It would be a publicly accessible web tool. You could put in the name of any tax-exempt hospital around the country. Frankly, you could put in the name of any hospital, and if it's not tax-exempt, it'll pop up and say, oops, that's not a tax-exempt hospital. So we don't ask people to know too much before they go to the tool. But if anyone, for a variety of reasons, in particular the community-based groups working with the hospitals to think about how we're going to address community health needs, the web tool is an easily accessible place where we put this in a context. So we don't give you access to the Schedule H worksheet. What we do is, and this is a prototype with 10 states, District of Columbia. I'll tell you a little bit about the feedback we received, which was very positive and supportive about the function that it serves and how, in combination with all of the other resources, this could be a powerful tool to really drive improvements in community health. But the way the tool, the prototype right now is structured is you would find your hospital either because you could click on a state and it'll list all the tax-exempt hospitals and you can click on it, or you know the name of the hospital, you would click and put it in. The first page you would get is a very easy to understand presentation of the allocation of community benefit dollars among those 9 approvable categories. So let's say it's, again, Hospital H. It'll just list for you those 9 categories, the allocation of dollars, and there are these little helpful things throughout that says if you don't know what the meaning of this word is, click here. So it easily helps you go through to see what those categories are, reminder of what the categories, how they're defined, but most importantly, it's telling you how those dollars are allocated. And we've tried to make this as simple as possible because we really would like this very much to be a really helpful tool for folks at the community level who are interested in partnerships and working closely with the hospitals to move the needle a little on getting more of the dollars into community health improvement and population-based strategies. So it's fairly simple to engage that first piece. Then we say, gee, would you like to know more? And if you'd like to know more, you can go to the next section. And the next section says, here's some context that might be helpful. Are you in a state that has expanded Medicaid? Are you in a state that has a state law that requires reporting on community benefit? Would you like to know a little bit about the demographics in the community in which this hospital is located? Because we're trying increasingly to help people appreciate not only the numbers, but the context. What are the demands on the hospital so that you can reasonably think a little bit about what you want to ask the hospital for and what those expectations might be. So another section on the community health needs assessment. And then the fourth section is a section that allows you to make comparisons. So you could look at your hospital and compare your hospital. Let's say you're a children's hospital. You can compare the allocations to all the other children's hospitals. You can compare the allocation to other teaching hospitals. You could compare the allocation to other religiously affiliated hospitals. You could compare the allocations to other hospitals in your local community, the region, the county, or the state. That piece, I have to say, during the prototype testing, we got a lot of positive feedback about the fact that you can not only get the information about your individual hospital, but that you could do some comparisons to get a sense of what are some of the other behaviors, what are some of the things you might be able to ask for. And we're trying to do that in a responsible way so that no 2 hospital communities are exactly the same. The pressures on different hospitals and communities are different. So to some degree, you want to try to make as fair comparisons as you possibly can, but we're hoping the tool is going to be able to do that. We've worked with colleagues at Northeastern University. The gentleman who published the study in the New England Journal of Medicine has been helping us retrieve the information from the IRS to put into the prototype. RTI International is designing the tool, and Community Catalyst, a nonprofit organization in Boston that does a lot of consumer advocacy work in the health field, has been extremely helpful with us on a number of fronts, but in particular in the prototype phase testing. So why are we developing this? For a variety of reasons. Access, remember, hard to find that information, but we think it's key to be able to make an informed ask, if you will, or openness for partnership with a hospital. If you're going to ask for people to spend more of those community benefit dollars in community health improvement activities, might be a good idea to see how much is being reported there and what you think might be a reasonable opportunity. To inform, to provide potential community partners and others with information that they need to have constructive conversations. We don't think it's a little difficult to go to the hospital if you don't have this information. The comparison piece, better understand how that compares to others. And then to educate folks, not only about the existence of community benefit dollars as one way in which we'll advance programs that address prevention and wellness, but hopefully can be used in combination with others to really result in improved community health. So we think there's all sorts of opportunities for collaboration, for allocating community benefit resources to advance the goals of the Affordable Care Act, and to address social determinants of health through investments in upstream evidence-based public health strategies. It's a source of dollars many of us don't think about when we're thinking about trying to support the kinds of programs that all of you work on, in particular, the medical legal partnership. I mean, this is just a project, a program and services that are so ripe, I think, for support and investment under the community benefit allocations. And I've spoken with a few of you and a couple of you in detail about how we might continue to help hospitals perceive this as a real investment and opportunity through the community benefit spending. And many of you have been doing that for some time. I think better understanding community benefit gives you another place to go, a way to think about engaging with the hospital. So what can you do? I would strongly encourage, if you have not already done this, to engage and inform key hospital leaders about medical legal partnerships. Most tax-exempt hospitals, they must post their community health needs assessment on the website. So you should be able to find that easily. There's almost always a name associated with that. If not, just go for community benefit on that website. You'll probably identify someone. If not, go to the CEO. Call the CEO's office. They'll know who's in charge of community benefit at that hospital, and begin to have a conversation with them about the allocation of community benefit dollars and about the merits of investing in medical legal partnerships. I strongly encourage you, if you're not already doing this as well, and in the Q&A we can learn how many of you already are, to participate in those community health needs assessments. They will occur every 3 years. There is an expectation and a requirement that they be done in consultation with community leaders. And I really think with the expertise and background that so many of you have in the medical legal partnership, it would be invaluable to have your perspective and expertise at that table as the needs are getting identified. So that first things first, you're part of the process where the needs are identified for the community. Be part of that process that identifies an implementation strategy, and then be smart enough, once we get the tool up and running for 50 states, to know to go to that resource and be able to figure out how has the hospital been allocating its dollars, how can you come together as a community to think about pushing for more in community health improvement and community building. And then any of you who have been doing this, if you could help us document the kinds of experiences, and we're going to talk to Woody about that right now, the kinds of experiences you're having, because I think the more that we can not only document it so that it's helpful in terms of those safe harbor kinds of things I was talking about earlier, but so that other hospitals and other general councils can see that in fact some hospitals have done this and it's been approved and accepted by the IRS. Before I close, I want to say that's one of the other things that we've been trying very hard to do through the use of this prototype that we've developed, and hopefully the full 50-state tool, and our work on community benefit. Forever, community benefit, for the most part, has been thought of as an IRS compliance issue. You've got to do this or you'll lose your tax-exempt status. Super important. I understand the priority that is placed on that. But now that it's also included, provisions are included in the Affordable Care Act, and we as a society are trying to think about how are the different ways, where are the different sources of money that we can use to help move the programs to be aligned with the goals and objectives of our health system, which is wellness and prevention. How are we going to do that? We've been trying to frame the use of community benefit dollars as not solely an IRS compliance issue, but actually part of the strategy for being able to get to the place that many of us want to get to, which is that we have a health system that addresses and focuses on prevention and wellness. So at the end of the day, I just wanted to say, I just think it's a moment of, we all know this, we use this word all the time, we are undergoing a major transformation. We are all being asked, or we're asking many of the players in the health system, to think about old assumptions, to think differently. We're trying to align dollars with the outcomes that we want. The Medical Legal Partnership Program has long challenged old assumptions and made a strong case for investing in legal supports to drive health outcomes. I truly believe community benefit offers an opportunity to align your gifts and talents with addressing community health needs in a process that has been mandated by the government and is going to be taking place every 3 years in your local communities. So thank you so much for your time today for the Community Benefit 101. The plug for the prototype and the tool that we're developing as a resource, I hope, for all of you and many others to be able to have the constructive conversations with hospitals and hospital systems. And at the end of the day, it's all about identifying need, designing strategies, aligning dollars with those strategies, so that in fact, We're investing in evidence-based public health strategies we know actually address those root causes, the upstream challenges, and at the end of the day, we'll begin to actually improve community health as a result of having paid close attention to the availability of these partners, these resources, and this moment in time. So thanks very much. I'm going to sit down, ask Woody to share a few words with us, and then we're going to engage in a conversation and open up for some questions. Thank you.